Welcome to the first installment in the Spring 2019 Trends in Behavioral Health webinar series. This series is a collaboration between Epstein Becker Green, Nelson Hardiman, and the Behavioral Health Association of Providers. Today's webinar is titled Unpacking the Support for Patients and Communities Act. Before we begin the presentation, please note that today's webinar is being recorded and participant phone lines will be placed on mute throughout the program. You are welcome to submit questions directly to the presenters during and after the webinar. Their contact information will also be displayed at the end of the presentation for your reference. In 2 to 3 business days, Epstein Becker Green will email all registrants a link to access a recording of today's program and PowerPoint materials. I am pleased to welcome today's presenters, Harry Nelson, founder and managing partner of Nelson Hardiman. We're also joined by Paul Gilbert, a member of the firm in Epstein Becker Green's Healthcare and Life Sciences practice. At this time, I'd like to turn the presentation over to Paul.
Great, thank you. We at Epstein Becker are pleased to present this latest installment of our monthly behavioral health webinar series, one that we are doing together with Nelson Hardiman, today with Harry Nelson. Before we get started, given the scope of the Support Act and the speed with which it moved through Congress and then was signed into law, it seems to be that an additional caveat is probably necessary with respect to today's presentation. In short, and I say this with a warm smile, be careful when interpreting provisions of the Act. Specifically, we intend to focus today on the Eliminating Kickbacks and Recovery Act contained within the Support Act. This, of course, is a new, well-intentioned, criminal anti-kickback law. This new anti-kickback statute, when read together with anti-kickback classic, if you will create or has created questions of application and interpretation. Secondary materials seem to me to only complicate these questions that have arisen. While there is some very relevant legislative history around the Support Act was not, generally speaking, well informed by extensive public hearings or input, so questions around interpretation and meaning are not surprising. Our respective firms likely have or will have clients who seek advice regarding the most appropriate interpretation and application of the Support Act to their particular circumstances. So as is always the case, different clients in our respective firms may take different positions with respect to the interpretation and application of the Act. Nothing that is said in today's seminar is intended to or should be interpreted as a statement of our respective firms' positions or legal advice with respect to any matter. So with that said, Harry, I'll turn the call over to you.
Thank you. Thanks, Paul. It's great to be able to present today with you and with Epstein Becker, we appreciate your comments because so much of this, particularly, is so new, this is confusing territory. But with that, let's dive in. Our agenda for the next hour is to cover the following things. First, just to provide a little bit of background on H.R. 6. And specifically the Eliminating Kickbacks in Recovery Act, the patient brokering law, providing a little bit of context on why the federal government perceived this new law to be necessary, providing the who, what, when, the details of the new law, talking about its implications for the addiction treatment industry, and finally leaving some time for questions and answers. So with that, we will dive in. We can go to the next slide. So H.R. 6, as it was known, it was formally titled the Substance Use Disorder Prevention that Promotes Opioid Recovery and Treatment Support for Patients and Community Act. It was enacted in October of 2018. Just some important high-level details. It was a bipartisan bill. It was a follow-up to the 2016 bill at the end of the Obama administration, known as CARA, it's interesting to look at broadly as a trajectory of where federal legislation and federal priorities have moved for the opioid crisis. And it's important to note that what we're really talking about today is just one piece of it. It really was an omnibus bill with 58 separate bills and a lot more to talk about. In fact, more that we'll be talking about on, I believe, in future webinars in the same series. Next slide, please. So just very quickly, at a high level, some of the other pieces of H.R. 6's 58 bills that we're not covering today included some interesting pieces like a law known as Jesse's Law, which changes some of the privacy and access to records issues in addiction treatment context, a partial repeal of the IMD exclusion, which was very important for access to Medicaid populations, a significant focus on expanding patient access to various forms of medication-assisted treatment, and particularly buprenorphine, which has been the focal point of efforts for opioid treatment through MAT in addition to methadone, a new mandatory e-prescribing requirement for Medicare Part D, an emphasis on peer support communities and providing resources for those, and expanding use of telehealth. Again, this is very high level, but those are just some of the other key parts of what H.R. 6 tried to do. Next slide. So, we're going to so before we get into the details of the specific law, let's just talk about the context of why this law was necessary. We've had the federal anti-kickback statute, the anti-kickback statute classic that Paul referred to for nearly 50 years, since 1972 in its current form, and essentially the problems that we've been seeing in the addiction treatment industry and around laboratories for urine testing are old problems, problems like fraud, intentional misrepresentation, and submission of claims that were unwarranted, abusive practices, the submission of medically unnecessary charges, and waste. Those are universal problems throughout healthcare that the anti-kickback statute has targeted. What we saw is that there was a new level of government and public interest in the problems of patient brokering in addiction treatment, specifically because of the 2 points that I've highlighted on the slide in red, specifically that in the addiction treatment context, these same issues, which are universal throughout the rest of the healthcare industry, also involve a significant safety component that we see reflected in the opioid crisis, insofar as patients are dying, overdose deaths, suicidality, and patient mismanagement have become much worse problems and are seen as flowing from patients being in the wrong facilities as a result, or in the wrong settings as a result of misdirection through patient brokering. And just more broadly, given the desperation of getting patient access, there was a comment from Sanjay Gupta, the CNN commentator I heard this past week in San Francisco, that effectively we're talking about roughly 10% of the people who need addiction treatment, who self-report as needing addiction treatment, are actually getting it. So in this context of desperation around access to care, having patients misdirected has led to a heightened public concern that that's one of the pieces underlying the Act. Next slide, please. So just as a little bit of background, what is the classic anti-kickback statute? It was enacted in 1972, and it prohibits knowing and willfully giving or getting anything of value in cash and kind that leads to claims being submitted to federal programs like Medicare and Medicaid, and that has been the dominant law that has guided, the direction that attorneys have given clients and that healthcare organizations have used to navigate what are permissible exchanges of value that are connected to the generation of to the marketing and business development of healthcare organizations. So we've had that law with us for nearly 50 years, and so it's sort of the question is, why did we need this new law? Next slide, please. So the best answers are first and foremost that the federal anti-kickback statute did not apply to any programs that were not federal health programs, federally funded health programs. It doesn't, federal anti-kickback statute does not apply to commercial or employer-funded health plans. And there was a gap because so much addiction treatment has been funded by commercial and employer-sponsored plans as opposed to Medicare, Medicaid, and other federal health programs. I think another reason that there was a perceived need for a new law is simply that there have not been enough resources at the state level. So given that federal anti-kickback statute does not apply, the legal infrastructure, both the laws and the regulatory agencies tasked with policing the issues of fraud and abuse occurring in commercial and employer-funded plans have predominantly been state programs, and there has been a perception that there simply are too few resources at the state level and local level to adequately address the problem. And we've seen that reflected in very negative media attention in California and Florida in particular, with some of the abuses that have gone largely unchecked by state and local resources. A separate related issue has been. Oh, sorry, Paul. Yeah.
I'm sorry. I didn't mean to cut you off, but before you moved on, I wanted to ask you. You know, in law school, we hear bad facts make bad law. We know there are a few bad actors in the industry. Certainly, those listening to this call probably don't fall within that description. But nevertheless, we are going to have to deal with these new provisions, which will be cumbersome, and frankly, if mistakes are made, will be costly to defend. In light of that, and in light of the fact of the stigma attached to treatment and to the numbers of those seeking treatment, you cited 10%. That's a number I'm familiar with. Are you concerned that the new law will further reduce the number of people who seek treatment or who are made aware that treatment is available to them? Are there going to be some unintended consequences here just based on the acts of a few bad apples?
I think I certainly agree with your point and appreciate it. I think and the people who are paying attention to the conversation and participating in our call today represent the overwhelming, in my perception, the overwhelming majority of the industry that are trying to do things the right way and to meet this need. And I think it's clear that what we're seeing is that the abuses by a few are leading to the entire industry being tarred with a brush of negativity and leading to, and I think by extension to your point, leading to I see a lot of resistance coming from health plans who have picked up that argument and are using it to be particularly aggressive in not paying claims. And to your point, it may also be it's a challenge with respect to patient concerns and really creating a negative perception that good actors in behavioral health and addiction treatment need to overcome. And I think this is absolutely the abuses that were covered here in California by the Orange County Register in the Riviera Recovery Riviera series that they published, and some of the others in Florida have really been a problem with implications all over the place.
Yeah, I agree with that. I think actually, and this was not intended as a plug, but we a seminar in the future that will speak to how to effectively and properly market in the space. And I think that, again, I didn't intend to make a plug by asking a question. But I do think that's going to be an important topic. How do we do this correctly? How do we reach a larger number of people who need the help? And how do we make sure that we can get the help to the people that need it while still being compliant? So I appreciate your thoughts there. Thank you.
100%. So just a final thought on this slide is that given that both the challenge of limited state resources and inconsistencies in state laws from state to state, there was a perception that the federal government needed to step in to provide resources and expertise to address this problem, particularly because we've seen significant federal focus on related issues that we'll talk about on some of the upcoming slides. So since the late 2000s, the federal government has already been trying to address the problem of how to move beyond the limits of the classic anti-kickback statute And what we've seen is that particularly in the area of urine drug screening and laboratory fraud, since 2008, 2009, in a series of cases around the country, the Department of Justice, largely with FBI support, have relied upon a series of older laws, such as the Interstate Travel Act and the Wire Fraud Act, to use these laws in order to prosecute patient brokering and healthcare fraud that is completely outside of federal programs and against commercial insurance and employer-sponsored programs. So we've seen that the use of those laws was sort of foreshadowed that there was a perceived need for a new mechanism to make it easier, essentially, for federal investigators and federal prosecutors to address fraud issues that aren't being adequately addressed at the state level. So let's get into the specific details of the Eliminating Kickbacks in Recovery Act, or ECRA, as we'll also refer to it. So first, the core provision of the law, Section 220, makes it illegal to knowingly and willfully solicit, receive, or offer to pay remuneration for referrals to induce the referral of a patient or in exchange for a patient in three settings. In other words, to give or get anything of value that leads to a patient being referred to a recovery home, essentially a sober living facility, a clinical treatment facility for addiction treatment or behavioral health, or a laboratory. So those are the three settings that where patient referrals were being targeted in the new law. Next slide, please. So the law provides, just to give a little bit more detail, the law provides that for criminal penalties for anyone who gives, gets, or tries to give or get anything of value for referring to a clinical treatment facility. That includes treatment in a medical setting other than a hospital, according to the language of the law, that provides detoxification, risk reduction, outpatient, residential treatment, or rehabilitation for substance use disorders in a licensed or certified setting. So the definition of clinical treatment facility is a new definition that anybody listening to the call should be paying attention to determine if this law applies to you. The next category was this category of recovery home, also a new category of definition for federal law. And it was defined as a shared living environment that is or purports to be free from alcohol and illicit drug use, centered on peer support and connection to services that promote sustained recovery from substance use disorder. The recovery home has been a term like recovery residences that we've seen increasingly used for for facilities that around the country take different names: sober housing, sober living, the unlicensed category of facilities that provide housing for people in recovery from addiction. And finally, the third category, which Paul mentioned at the beginning of the call, the law covers anybody trying to give, get, or anything of value for making referrals to laboratories. So the concept here of remuneration is essentially the same as under the classic AntiKickback statute. It encompasses anything given of value, whether cash or cash equivalent or gifts, and the concept embedded in the law, as in the Anti-Kickback statute, is the concept of inducing. Is the thing being given or received in order to persuade somebody to make a referral? The consequence of the law is each violation was punishable by up to 10 years imprisonment and a $200,000 fine. And one interesting comment here, Florida in 2016 passed a patient brokering law specific to addiction treatment that included similar penalty levels. It was very interesting in the fall of 2018 when California passed a state-specific patient brokering law that the state declined to put any criminal penalty on the law due to a belief that the California prisons simply didn't have room for more potential violators of the California law. So in California, this and other states that don't have a specific criminal penalty, the new law has an even more significant implication than in places like Florida, where there was an existing state law.
And Harry, these consequences are extraordinary. And for those listening who have not had the pleasure ever of dealing with Kickback Classic, as I guess I'm going to start calling it, these are very, very significant penalties, without question. I think on their face, they're significant. My sense is this was driven by, again, publicity around the bad actors, and it'll be interesting to see as enforcement occurs how these penalties are used and whether flexibility gets built into the system.
Yeah, Paul, the one thing I can certainly comment on is, having seen, been involved in over the years extensively in negotiations of cases with federal prosecutors, prosecutors' jobs get easier when cases which inevitably involve multiple violations start to have very large financial, very large numbers attached to them,
yes,
and large terms of imprisonment. So I agree with you. The significance of a $200,000 fine on each violation makes it very easy to see how we will violators are potentially going to be looking at multi-million-dollar liability, and I think the leverage for settlement of the U.S. Attorney's offices in pursuing these cases is going to be unusually strong relative to other federal healthcare laws based on this provision.
Yeah, couldn't agree more. I agree.
So when does the law take effect? This is a really important point that there seems to be a lot of misunderstanding on. Many states establish effective dates for new laws prospectively, or we'll say, for example, here in California, when the state legislature passes and the governor signs into a bill into law, it will often take effect on January of the following year. In federal law, there's a distinct principle, which is that when a law is silent, the effective date of a new federal law is on the date of enactment. And so in a case like this, where H.R. 6 was silent, the effective date of the Eliminating Kickbacks and Recovery Act is October 24th of last year. And so anybody who is who's thinking, or if you are in communication with people who are saying, yep, this is something we need to get ready for, down the line, it's very important to think again. This law is in effect as we are on this call today, and is something that needs to be accounted for immediately. One very important thing to note about the law with respect to Kickback Classic is the Eliminating Kickbacks and Recovery Act expressly states that it does not apply to any conduct that is prohibited under the federal Anti-Kickback statute. So essentially, what's very interesting is that the law expressly includes a carve-out. So if any conduct that, for example, claims that would be billed to Medicare for addiction treatment or laboratory services are and therefore would be covered by the federal anti-kickback statute would not be covered by this law. So it includes this express carve-out so that there is not dual liability risk under both laws. You're covered by one or the other, Kickback Classic or ECRA, and the law also expressly does not preempt separate state laws like those in California and Florida that I mentioned. So the law applies to services covered by any public or private plan or contract affecting commerce under which any medical benefit, item, or service is provided to any individual. It covers commercial health plans, employer-sponsored health plans, and government health plans as well, to the extent that, again, noting the carve-out stated on the previous slide. And so basically, other than excluding the conduct that's already prohibited by Kickback Classic, this law essentially covers all other services in the healthcare universe, with the possible exception of cash pay services. One
interesting question there, Harry, on what's covered and what isn't. is around providers that don't touch opioids, that don't treat addiction, that don't involve themselves in this business or in this treatment mechanism, if you will, and whether they were intended to be picked up. Relevant statutory interpretations constructs suggest, based on the history and the statements made around the law, including the express statements within the law, suggest that this law was intended to apply to, in effect, what is called generally as the opioid crisis. So those that are not acting with respect to the treatment of substance abuse disorder may very well fall outside of this statute. And I think that's one of the many questions that exist, just how far this statute goes, and is it really intended to be as broadly applied as it can be read if you want to read it that broadly?
No, I think you're right. I think it's a very interesting point. Going back to the language around, who was covered, what settings were referrals covered in. The inclusion of medical settings other than hospitals, opens up a huge potential category, and it's interesting. It's very clear that the heavy focus of the law seemed to be on outpatient and residential addiction treatment settings and sober living recovery residence settings, which the federal government has been effectively investigating in the context of urine drug testing for the last decade, but really has not had great tools to go after. But I think you're making your point's a good one, and it's going to be interesting to see how much more gets pulled into this, and important, certainly something that's important for any healthcare organization that touches addiction treatment or any of these services to think about. There's a lot of opportunities for other people to be caught in this net. So let's move on. So the statutory exceptions, the law ECRA does include certain specific exceptions, places where the law doesn't apply. It does not apply. This first one is very, very important. The law specifically includes a statutory exception to bona fide employees and independent contractors, including services that meet the federal anti-kickback statute, the Kickback Classic Safe Harbor for personal services and management contracts. And we'll talk about that on an upcoming slide about what that exception is. And there were also specific statutory exceptions for disclosed discounts under healthcare benefit programs related presumably to substance use disorder treatment, to discounts on drugs furnished under Medicare coverage gap discount programs, to certain co-insurance and co-payment waivers and discounts, and to federally qualified health center arrangements that already meet federal anti-kickback statute safe harbors. So those were just a few carve-outs, and they require, if you're going to be, if you're looking at them, it's very important to look at the specific language of the law and to consult with an attorney, because these were in some cases, for example, on the co-insurance exception, were narrow, and there are places where there is risk around inappropriately discounting. So let's turn to the subject of the big questions of what this law means for addiction treatment and for healthcare providers. So the overarching question that we were besieged with immediately after the passage of the law was, is it illegal to pay employees and independent contractors for marketing services? So the starting point here, this is tricky territory, and so I wanted to go back to, I thought it was useful to start off by talking about what the Kickback Classic permits in terms of contracts. And this law, it's important to say, this law applies, there is a separate federal anti-kickback statute that relates to employment relationships. This safe harbor protects relationships in which there is a written contract with a minimum term of a year that if less than full-time specifies precisely when services are going to be provided, that details carefully all services that are going to be provided under the relationship, and applies to services that don't involve any illegal activity, anything that would be otherwise prohibited, and that meet two financial tests. First, that where the aggregate volume of services are reasonably necessary to accomplish a commercially reasonable purpose in the absence of referrals, and finally, that the aggregate compensation set in advance is commensurate and consistent with fair market value without taking into account the volume or value of any referrals. So the answer is that there is still room for legitimate employment relationships and potentially independent contractor relationships around marketing, but it's very important to be paying attention to these standards, under the federal the kickback classic safe harbor, because they were referenced in the law. There clearly is room to employ somebody to provide marketing services if you're meeting these requirements. Paul, I'm not sure if you have any comments. The one thing I would say is that, in general, our view, has been that that anybody who is thinking about what marketing or other kinds of personal service compensation relationships should look like in addiction treatment should fully expect the federal prosecutors and others reviewing arrangements to apply the same level of rigor that we currently see in other parts of healthcare where the anti-kickback statute is applied, in hospital and physician organization settings, for example. So these are, in those settings, this safe harbor is well understood and is applied quite rigorously. And so these, like the word, when it says here commercially reasonable and fair market value, those terms have very specific meaning and become very, very important to map out and in establishing relationships.
And Harry, I was going to go directly to that point. What will become the practice around establishing commercially reasonable and fair market value arrangements in the hospital world, which is sort of where I come from and I know very well. We went to great expense and took great care to document in each instance our arrangements and to provide backup in cases of both fair market value and whether or not the arrangement was commercially reasonable in writing, often provided by third-party experts. So valuation firms were brought in. And that's an industry where the practice of compensating physicians and other referral sources is age-old. In this context, where where there is not an established practice or a sense of what the market value might be, there aren't studies available. There aren't third parties that have made general information available. I think it's going to be very interesting to see what people do here around documentation. And you're right. I mean, the review could not be more rigorous when the government comes in and wants to take a look at referral relationships. And the penalties, going back to those, are incredibly significant. And so the cost of compliance here could significantly increase. And then I can't also state or overstate the importance of maintaining in a central file, ideally, all of that information with respect to all of the people that are that fall within this category. So it's going to present some logistical and financial challenges in addition to the obvious compliance challenges.
I think it's that's all great points. The thing I would highlight, there are when it comes to for people who have been operating in addiction treatment in regions of the country where there has been where state laws are understood or enforced less rigorously, and I'll with respect to financial issues, and I'm just to be direct, California and a number of other Western states have been operators in those states may be used to having marketing relationships reviewed without going through the exercise that you're describing, Paul. I think it's different in other parts of the country, in states like Florida and New York, for example, that may have, and other states that have also taken the same kind of rigorous approach at the state level. But for people who are in California or other states where you have not had to go through that exercise before, I think one of the key takeaways that I would underscore is that it's now necessary to go through exactly what you were describing, Paul, and to really document carefully in a quantifiable way with outside support the legitimacy of relationships.
And that's something, maybe that deserves a call on its own, because it sounds simple in a way, but it really, once you get into it, you'll realize, I think people will realize that it can be extremely cumbersome, time-consuming. You might want to sign something up, real time with a new employee, and you realize, wait a second, we have to go through all of these steps, and so you have to think about planning your business in a different way. You have to think about, again, maintaining the documentation in a centralized location you can have ready access to, and the ability to produce this if you are reviewed or investigated, to use a more aggressive word, just can't be overstated. So it's bad.
Sure.
I hate sort of being the bearer of bad news, but this is one of the consequences of those bad actors that I think all of us now are going to be, dealing with.
Yep. All right. So I think that if we can move to the next slide, we've covered this. So this is essentially where, before we get to the big issue of bonuses, the bottom line is that the law does not ban payments to employees or independent contractors that for marketing services, and there clearly is an ability to pay on the standards we described on the last states, and this slide just emphasizes that point about the value of getting independent valuation experts. So we can move to the next slide. We'll get to the real, the question of what you can no longer do. So one thing, and this is where the compensation and marketing language leaves some room open. The new law expressly prohibits employers from paying independent contractors and employees based on metrics like the number of individuals referred, the number of tests or procedures performed, and the amounts billed or received in whole or in part from healthcare programs. So this means that employers can't pay employees or independent contractors success bonuses, which is in contrast to kickback classic allowances that have emerged for the allowance to pay some bonus component, not to independent contractors, but to employees for productivity. And this has been one of the single biggest points of contention. And if we could just go to the next slide to finish the point, and Paul, I want to get your take on this. But if we can move to the next slide, Sorry, I'm having trouble. Seem to have trouble.
Yeah.
Well, here we go. So here's the issue. So this is really the question: is based at this point in the discussion, we've established that you can still have legitimate contracts that meet the safe harbor requirements with employees or outside marketers, but then we've got this limit now in ECRA, which says you can't pay people for the number of individuals referred, the number of tests performed, and the amount billed or received from insurance, from health plans. And so the problem is that we've historically had under Kickback Classic an allowance in the safe harbor for employees that allowed for bonuses to be paid not to contractors but to W-2 employees if those bonuses were commercially reasonable and had reasonable allocations of salary and bonus, clearly with a preference that bonuses be based on a number of factors other than just individual productivity, like the overall success of the business or patient satisfaction, some other metrics. But there has been some allowance for bonuses to be paid. And now the big question that everybody who's thinking about entering into contracts with employees for to include that or that has productivity bonuses really needs to ask is, can we safely assume that these that these principles on the screen, which we've relied upon under Kickback Classic, are also going to apply under ECRA. And frankly, I think the answer is we don't know yet. And so this is a very difficult question that every treatment provider that is paying productivity-based amounts needs to be taking a careful look at and getting advice on. So, another hot question beyond the question of whether you can still pay some kind of productivity-based bonus is the question of discounts or waivers to pay for patients' travel, and so that's another area. The issue here, of course, is that when programs are paying for patients to travel, often interstate, to come to programs, there is a concern that the patient is being induced to choose a particular treatment program because one program covered travel when another program may not have, and so that essentially it amounted to an inducement to the patient directly by covering the travel. So in our takeaway from the new law makes clear that it's a crime to offer a patient a waiver of discounts or deductibles of coinsurance deductibles and copayments. And there are exceptions. The law provides exceptions if the waiver or discount is not routinely provided and is occurring in good faith. But this too also requires careful analysis. I want to add here also it's very important to look at this issue under the terms of the laws of the particular state, which are also different around the country. But the bottom line is that our understanding is that there's still room for addiction treatment and recovery programs to provide limited discounts to patients in genuine cases of documented financial hardship. But again, that has to be done carefully. And the other point here is that the law prohibits anything of value from being exchanged to sober livings, to recovery homes, not only to treatment programs, and so it creates a risk of paying for travel that applies more broadly.
Yeah, this is a big one. It's a common question we get. I can't tell you how many times I've been on the phone giving advice around hardship programs and policies, written policies, to be put in place to avoid scrutiny from private payers, commercial payers, Harry. And now, in this framework, you described it correctly so as a crime to do this. And so the written protections and the guidelines and following up to make sure you have clear standards with respect to a documented hardship, financial hardship, have moved from being really important to stay on good terms with commercial payers and ultimately the government, but in today's world to avoid committing a crime. So I think this is a very important page, and I think a way to be compliant with an issue that's fairly common, but again, something to pay attention to.
Yeah, and the only other thing I would add on this slide, Paul, is that we see a lot of liberal practices out there. A lot of facilities that are treatment programs that are taking liberties in offering discounts and covering travel. And the one thing I would say is that again there's a lot of to be seen about how closely the federal government will follow Kickback Classic interpretations as ECRA applies. But we do see that those issues of travel and discounts, hardship discounts, do come up in other healthcare settings. And in general, it's useful to look at models that have been accepted in those settings and to work with advisors who are familiar with those models to get to practices that have less risk attached to them.
Yeah, absolutely agree. It's an area where we can learn from other areas.
So
other
this was, I made the point on the previous slide, but this the point here was just that it's important when we think of inducements, we often, when we think, the name of the law, Eliminating Kickbacks in Recovery, the title of the statute is pointing towards the image in people's mind of marketers who are out there, soliciting patients either digitally or in the real world, and then selling them to programs. What's important to remember is that the law also covers these inducements that are given directly to a client or the patient or the patient's family to influence their decision. That this category of kickbacks is not only a kickback to a marketer, it also is potentially a kickback to the patient himself or herself. And so in general, because the issue of air travel comes up so often with interstate people moving across state lines to go to treatment programs, we do have guidance from the Anti-Kickback Statute that there is an allowance for limited ground travel that exists under the Anti-Kickback Statute, but it's very clear under existing federal law that there is no allowance whatsoever to pay for travel to pay for air travel or to pay for luxury travel for patients to attend programs. The federal allowance that exists under Kickback Classic is for a 25-mile ground transport, 50 in rural areas, but nothing. It expressly prohibits air travel. So there's no basis whatsoever for anybody to imagine that covering the cost of the patient's flight is legally permissible. And the only option that really seems to be available is to consider a finance relationship, and I say this with extreme caution because it's truly got to be done in a way that is legitimate, where patients it is possible to make loans to patients and patient families, but those have to be real. They cannot be sham arrangements. I'll just say that we've presented some of the models that the Behavioral Health Association providers developed to health plans and have received a positive reception, but also a lot of wariness that there are many, unfortunately, there are many people out there who are paying lip service to promissory notes and financing relationships, but really just using them as a cover, and that's not something that anybody should feel comfortable about under ECRA. So this is I preempted the slide. Sorry, the federal program guidance under Kickback Classic has been that the allowance to give transportation is when you have a consistently applied policy, when the value or volume of patients is not tied to is not tied to the provision of transport, when it's not air, luxury, or ambulance transport. And this is very important, when you're not marketing the transportation, and again, only for established patients in this 25-mile zone in urban areas and 50 miles in rural areas, and when the entity paying is the provider. So the place where this rule is relevant and may be helpful is in treatment programs and recovery housing providers that are shuttling patients, back and forth for day programs, for example. This federal allowance may be a useful guidepost for that purpose. So we just wanted to offer, we have got about 10 minutes for questions at the end, but we just wanted to offer a few final thoughts. We can go to the next slide. So we are expecting a significant uptick in prosecutions under ECRA. One of the questions that's fair to ask anytime a new law is passed is how much enforcement activity is going to start. Is it going to take years and years for federal enforcement to start, as we've seen under other laws? For example, in the data privacy and security context, when it took years and years after laws were enacted to actually see enforcement under those laws. And our view is that there's not going to be a long delay here, that this is a priority for the FBI, for federal prosecutors, and given the pressure that Paul's been talking about some of the negative attention to this issue, and also because we've seen that the health plans have been limited in their resources and have been developing better and better fraud and abuse detection capacity, but without the ability to do anything beyond, not paying or demanding repayment. So what we've seen is that increasingly the health plans have been working hand in hand with law enforcement, and we believe that ECRA is going to basically play into more use of data gathered about inappropriate relationships based on analytics of referral patterns to support prosecutions in the very near term. We also, I believe that there's some pent-up demand for prosecutions because referrals to the state and local authorities, which the health plans have been making, have really produced only a relatively limited number of cases. Here in California, it's very striking that Orange County has been this epicenter of health plan law enforcement collaboration and has been the high water mark, but we believe that there's going to be that ECRA presents a likelihood of a significant ramping up just because of the resources available. And so ultimately, we think that the insurance companies are likely to be some of the leading whistleblowers with a small lowercase w in initiating, in providing information under ECRA, and also alongside all of the existing federal investigations that have been ongoing in the urine drug screening lab fraud cases that have been prosecuted. So for all of these reasons, we think that this law is going to be a big deal that providers, that everybody covered by it needs to be paying close attention to.
A big deal indeed. And in the last 5 years, we have seen a significant uptick in audits by commercial payers. No surprise to anybody on this call. But the fact now that that information, that collection of information, access to information, is now going to, in effect, be a team approach between those commercial payers and the government enforcement agencies is something that should be taken seriously. And patient brokering, as used here, is certainly a pejorative, but the activities that are picked up under ECRA are so much broader than the sort of front-page horrible patient brokering stories that we hear. This is something really to pay attention to, Harry, and I think you've made a great point. It's a reason to be compliant, as you said, back to the effective date of the statute, which is now in the past. So we all have to come into compliance.
All right, so we want to leave time for questions. So just very quickly, if we can go to the next couple of slides. A very important, just a couple high-level points here. One point of emphasis is it's very important for organizational leaders to be aware of that in federal prosecutions we often see that atmospherics, that statements made that put pressure on marketers are grounds for federal concern. So that's something to pay attention to. Very important not to ignore state anti-kickback statutes. As we mentioned, those are still fully in effect, and it's very important. Those are very different from state to state, and it's important to pay attention to this point. And so some of the high-risk activities that we talked about a little bit on this presentation, including the waiving or discounting of patient financial responsibility, urine drug screening, as we talked about. It's going to be interesting to see. We believe that call centers and digital lead generation, which have played a big role in addiction treatment, are likely to get some scrutiny in the future under the law, and that referral relationships with physicians and other health professionals are also likely to be a high-risk activity that should get attention. Finally, we've seen a number of cases coming around the country about procuring insurance has become something that some marketers have done. In other words, somebody with an addiction issue will be identified, and then that person will get insurance either from a marketer or in some cases from a treatment program and that is a very high-risk activity which we expect to see prosecuted. Another huge frontier is going to be the business arrangements between recovery, housing, and addiction treatment. Bed vouchers is a common term that we hear used in California for these arrangements where the outpatient treatment program, which is getting insurance reimbursement, is paying for a bed from a recovery residence that's referring a patient, and that is going to be an activity that's going to receive a lot of scrutiny, we believe. So a final slide before we take some questions. We expect this ECRA to be used substantially in the very near future, and it's just important to remember that it's not intended to ban all addiction treatment marketing, but it makes it very important to do things the right way. We hear a lot of feedback that we've got to engage in practice X because everybody else in the field is doing it, and it's important to remember that that's not going to be a defense when these cases start popping up and investigations start. And finally, we believe that in putting on this webinar, a belief that I know we share with Paul and Epstein Becker is that the more that healthcare organizations can move to a strategic approach instead of operating in fear of these laws and address skeletons in the closet, there's an opportunity to make these a part of your strategy for success rather than just a burden on your operations.
Absolutely, and it's a great way. Making that kind of progress is a great way to develop credibility with the agencies that will be looking over your shoulder. So seeing it in a positive way as opposed to a negative way, I think, is really important. And the law is in place now, so we all have to comply with it in a good faith way. So Harry, time to move on to questions. I think so. I think you were finished, weren't you?
Yeah. Okay. Please.
So here's an interesting one. Does ECRA have any implications on insurance companies or providers covering some treatment facilities and not others, or only referring to in-house treatment options? So in other words, do the kickback provisions go to where commercial providers or payers can send their patients?
It's an interesting question. To me, that raised, the question was raising really a parity, something that's really right. More of a parity issue than we don't see federal prosecution. Our read of ECRA is very much informed by the history of federal prosecutions over the past decade in the drug treatment industry. And so while I think the question is pointing towards a legitimate a question about another kind of steering activity by insurance companies only covering particular programs, that's not where we see federal interest it's likely to be addressed. I think that's going to have to be addressed through parity enforcement.
And I do think there is a lot. I agree with you. I do think there is a lot of activity, though, around parity. I think that effort is building and has gotten to the point where it's become a real issue for employers and for commercial payers. So while this may not help, the parity implications of providing care generally are going to be helpful. Another, and maybe on a more upbeat note as opposed to the kickback, but a question around the expanded access to MAT provided generally in the Support Act, not by ECRA, but in the Support Act. Do you have thoughts on that? Can you generally just sort of summarize what happened there and how that might change the availability of treatment?
Wait, sorry, Paul, I lost your
the expanded access to MAT, the ability of providers now, more providers to write prescriptions for medically assisted treatment, and do you see that as an important aspect of the Support Act?
Oh, absolutely. It's very clear, and I've been involved in some conversations with federal policy folks at different agencies. it's very clear that that was a big push of the law was to expand MAT. MAT has been there have been a few challenges, barriers to MAT. One has been the lack of Medicaid provision, but the training requirements, the limitations. One of the most significant things in the law was the making permanent the right of physician assistants and nurse practitioners who undergo the training to be able to prescribe. There still is a 24-hour training. There are still barriers out there like the need to get the DEA waiver to complete 8-hour training for physician, 24-hour training for physician extenders. But the law goes very far to open up more MAT and more, and that's a positive thing. One of the interesting challenges is that we're seeing that the addiction treatment industry has been very abstinence focused and has not, and there's going to be it's a challenge to integrate the substance use disorder treatment traditional approach with this new push to expand MAT, and California for example just passed a new a law to prohibit discrimination that's getting a lot of attention and raising a lot of questions.
Yeah, so I think it's a huge opportunity, and I think that for providers who haven't focused necessarily on MAT, building it into the program and taking advantage of these new provisions in a positive way, taking advantage of the new provisions that encourage MAT treatments, is a plus and a real opportunity here under the statute. So if you haven't focused on those, you might talk to counsel about how you can do that and get involved in those areas. And then in terms of follow up around this topic, Harry, are you familiar with sources of good information on these topics that people might want to tap into?
So, I'll take that as a shameless plug for, BHAP, the Behavioral Health Association providers, who, in full disclosure, I chair the board of. We have been really trying to make a huge push here to get information out, and have created a 36-hour training course that people can take remotely, and that's being offered at conferences around the country that goes through standards, and we've been receiving great feedback on it. And I would strongly encourage people to check out that resource if they're looking for more information, particularly something geared for marketers and anybody involved in addiction treatment marketing. Perfect.
Thank you, Harry. With that, I think we are finished for today. I'll turn it back to the team at EBG.
Thank you so much, Paul.
Thank you, Harry.
So this concludes today's webinar. As a reminder, in 2 to 3 business days, Epstein Becker Green will email registrants a link to access a recording of the presentation and PowerPoint materials. Thank you for attending.